Thanks, Pranay. Good evening, everyone. We'll be talking on one of the very important aspects in ECMO. As you know, ec- infections on ECMO contribute to lot of mortality worldwide and more so in our country as well. Approximately 40% of the mortality is attributable to infections on ECMO. This message from Socrates was right. I cannot teach anybody anything, but I can only make them think. So, um, the take home message from my talk today is think about the way you are practicing infection control mechanisms and try to change if it is possible. Infections are the main reason why people go on to ECMO. We talk about incidences, prevention, antibiotic stewardship, as much as we can follow on ECMO and the dosing. This slide is very interesting. This shows about life on Earth. If you can see, bacteria appeared 3.5 billion years ago, and humans, with their evolution, they have evolved over a period of the last 2 million years with that. So, it is not possible for us to kill all the bacteria and ask them to go away because they are not going to do that. We have to live in symbiosis with them. We have friendly bacteria and pathogenic bacteria. Human body itself hosts trillions of bacteria in our infrastructure structure itself. Now, I read somewhere like for every cell of our body we carry three bacteria. So approximately like 3 trillion bacteria are there in the human body. I'm sure some of you might have heard about quorum sensing. Quorum sensing is the language in which bacteria communicate with each other. So it is very interesting to read about it and know more about it on YouTube videos. Also, you can watch about the quorum sensing and how it works. This is the mechanism by which bacteria tend to exchange their resistant genes. So, no doubt, infection is our biggest enemy. It causes economic losses, increases the morbidity and mortality, and reduces physician satisfaction when it happens. Our results could be much better without a hospital acquired infection during the stay of the patient. They are very important because they decide the duration of ECMO. They remind us about the need for introspection and our success or failure rates. They are ever so more important in resource limited countries as patient stay is directly proportional to the money they spend on ECMO. Root cause analysis is needed when it happens and use of effective antibiotics for the right duration, preventing fungal infections. The balance is very difficult, but one should try. In the current times, suspecting infection on ECMO is with reference to clinical parameters. When we do the blood counts, we can see a raised white cell count and low platelets. C-reactive protein can go up as well as the procalcitonin as well. Though it is talked about like procalcitonin is a good marker for infection than inflammation, but it does happen and both of them tend to go up in the presence of either infection or inflammation. Blood cultures, ideally, um, they are taken as the gold standard, but unfortunately, only in 40 to 50% of the cases, they tend to be positive, and a huge majority, despite the fact patient is having infection, blood cultures may not be positive. In ELSO registry data, Infections are very closely monitored about culture positive infections and white cell counts of less than 1500 in all the age groups neonatal, pediatric, adult, VV, and VA sets up. You can see here with reference to the neonatal VV group, only 40% have survived with this reported incidence of secondary infections. And in the adult VV group, around 53% have survived uh, in the hospital acquired infection group. So again, also statistics, the pediatric respiratory runs and adult respiratory runs here, mortality rate can be quite high with reduced survival. Routine cultures and prophylactic antibiotics are not indicated. At one time, nearly 15 years ago, we used to do that. But once we realized it is of no use, we don't do routine antibiotics just for the sake of ECMO run in a patient not suspected of having infection, or routine circuit cultures are also not needed. They are not going to be very helpful. In ECMO cases, mortality has gone up by 30 to 40% in Indian scenario, as per one of the studies we did in 2017. ECMO duration will increase by 1 week to 10 days at the minimum, and multi drug resistant flora will develop with their after effects on multi system failure. So that adds up to the complications of further organ failures, adding up to the mortality on ECMO. The common infections are gram negative, gram positive, and when the duration of antibiotic therapy gets prolonged or the immunity goes down, fungi tends to set in. You're all aware of the multi-drug resistant strains, and in most of the scenarios we have been seeing, viruses and bacteria tend to live together. The risk factors for sepsis are ventilator-associated pneumonias,
जब
uh,
मम्मी पास मम्मी चाहे
bloodstream
आए
bloodstream associated infections, and catheter related infections. It is very important to note that incidence of infection varies with ICU, with the antibiotic prescription policies and the protocols you follow in on your ICU. I mean to say, a neonatal ICU is different from a pediatric ICU and is different from adult medical or surgical ICU. It all depends on the prescription practices and the different protocols, including the hand hygiene, like antibiotic stewardship program practices, which you are following in your different ICUs in the same hospital. So you cannot equate all the ICUs together in one hospital and come out with a antibiotic policy. Infections acquired by adults are much more common. In this study by Cecil et al., they have quoted they are nearly 20, uh, 4 times as much as the 3 to 4 times as much as a neonatal population. In their study, 20% is the incidence of infection in adult patients, whereas 6% is the incidence in pediatric patients. This is another study from Dr. Ram Gopalakrishnan et al. When we published it in Indian Journal of Cardiothoracic Surgery, Cardiovascular Surgery in 2021 about the various organisms that have been isolated um, in ventilator associated pneumonias, cannula related infections, post sternotomy, and bloodstream infections. They can help as a guide, but certainly they tend to vary from institute to institute. The duration of ECMO wise, the longer a patient spends on ECMO, yes, definitely the infection rate also will go up. This is another study by Guan et al. About nosocomial infections on ECMO, demonstrating here close to 0% incidence of infection when the ECMO run is for 2 to 3 days versus nearly 100% infection when the ECMO days or more than 12 days. So, the prevalence of hospital acquired infections is variable from place to place. In this study by Stefano et al., they noticed 10 to 12% with a high probability of coagulase negative staphylococci, candida, enterobacteriaceae, and pseudomonas. High incidence of ventilator associated pneumonias were also reported in their study. COVID-19 duration as well. In that time, Ryan et al. They have shown uh, COVID-19 patients on ECMO were more vulnerable to invasive fungal infections such as invasive aspergillosis and candidiasis. It is a small study though. Again, another study by Mehernes et al. About the usage of uh, antifungal medications when you suspect fungal infections. Voriconazole or isavuconazole is recommended as a first line treatment option for COVID associated pulmonary aspergillosis. But certainly, it is for sure from Infectious Disease Society of America guidelines, and echinocandin is the first line of therapy for candida associated bloodstream infections. Liposomal amphotericin B is recommended in case of suspected confirmed azole resistance. So the basic principles play a lot of role, like washing hands. The importance of hand washing cannot be overemphasized. Soap, water, and common sense are the best antiseptics known as per William Osler, and it still stands good. In our experience, we found alcohol with chlorhexidine is the best solution if available that can be used, or next followed by alcohol without chlorhexidine, and then chlorhexidine comes the next. Chlorhexidine is a very useful agent for getting rid of the bacteria on the skin. A prep will be certainly recommended before cannulation or before contemplating any surgery on the ECMO patients. It helps in reducing the bacterial load on the patient. So, uh, then that way, the possibility of transmission of bacteria further into open wounds will become less and less with that. Superbugs don't respect borders, though New Delhi metal beta lactobase strain was identified and reported around 2005 time, but it is well known that it exists in many parts of the world. Though the nomenclature is wrong, attributing it to New Delhi, but these superbugs they exist all over the world. This is one study. Here are paper, not study as such. Actually, it's a news report stating drug-resistant bacterial contamination in water. This could be the same water which is supplied to us and which we will be drinking as well. So it is quite possible. For getting rid of these bacteria from the tap water, you need to run it through reverse osmosis process. So that's why we tend to have water purifiers at home for domestic use, and even in our ICUs also, we should have water supplied by the process of reverse osmosis technique. All of you can notice our operation theaters are provided with water uh, treated by reverse osmosis technique. Why not our ICUs? Other subtle things such as active ingredient of the drug and what are the drug levels in a particular patient, how do they metabolize the drug, what is the effect of toxicity if their kidneys have gone down or the hepatic decompensation has happened, what will happen in proportional to the hepatotoxicity and nephrotoxicity of the medications. Very important point here to note is after the prescribed duration of the intended use of the antibiotic, please de-escalate the medication. If you continue the antibiotic forever, the only outcome is drug resistant strains tend to develop. Bacteria are very, very clever. Definitely, they are going to develop drug resistant strains. So, in view of that, it's my plea to de escalate the antibiotics after the prescribed need for the underlying condition, either septicemia or pneumonia, etc., and then have a period of not having any antibiotic on the ECMO circuit, provided your environment is made free of bacteria or very less number of bacteria in those cases. Fungal prophylaxis certainly had to be thought of when your antibiotic duration is nearing 10 days or exceeding 10 days. In the neonatal practice, something like this can happen, and I have seen this happening as well. For example, a colistin a vial can last contain 150 milligrams in that. For adults, it is okay, but for neonates, this vial, once it is reconstituted, it can run for 4 or 5 days. So, if people use it for 4 to 5 days after reconstitution, it is not going to be uh, potent for all these 5 days. There is a prescribed duration on this for 24 hours, 36 hours after reconstitution of the drug. Then only it is going to maintain its potency. So, these things have to be taken care of. Having an alcohol rub or hand rub next to each and every patient is very important, and it is important uh, to resource as well as boost our nurses to prevent anyone uh, approaching the patient and examining the patient without cleaning their hands. So the nurses on the unit should be empowered. This is one of the practices at Krishna Institute of Medical Sciences. When I was there, like we were covering the central lines in a sterile gauze like this, which changes from day to day. The most advantage we felt out of this is because the nurse or the doctor recognizes this is a precious location which shouldn't be accessed without cleanliness. So people tend to use maximal precautions when they approach these central lines. So that's why central line related infections can be brought to the minimum. Some things like this should not be of natural occurrence as such. You can see here in the suction tap some leftover material is there, and obviously bacteria tend to grow in that. This is an unwelcoming sign, and they should be changed. And reflecting upon some of the common practices as well, like an echocardiography. When you're doing a vascular ultrasonography or echocardiography, we tend to use our ultrasound or echo probes without cleaning them as they should be. But we tend to transfer infections from patient to patient if used like that. One of the simple measures to prevent this is if you put gel in a glove, like a hand glove, and you put it on the top of the um, probe, then you can use it on the patient and you can throw the glove off after the procedure. So it takes away all the infection you're supposed to be carrying from person to person. Regularly used surfaces like this should be cleaned on daily basis, like the syringe pumps. And this is a very effective tool. It costs around 1 rupee or 2 rupees per plastic apron. If you wear them before examining a patient, especially when you are coming in contact with a patient's bed or related area, in this way it will prevent transmission of infection from the patient onto you and from you to the next patient, etc. They don't cost a lot, and even the hand gloves also are known to reduce the transmission of infection by 25%. These are not sterile gloves, but these are the normal gloves which we tend to use, the non-sterile gloves. So it reduces the incidence of infection by 25% as such. In this case, you can see her wound was dressed, and without their notice, they left some of these um, is dressing pads over there next to the patient. So they have contaminated the patient bedside. If you go on lean on to this area, even after this non-sterile uh, cotton swabs and the gauze pieces were cleaned also, still the bacteria can come onto your body, and from there they can be transferred to the further patient. So these things which we do inadvertently can be avoided if we focus on adequate attention. So rethink the ways we are functioning with respect to preventing infection in our country. It just needs thinking about the ways how we are doing and modification of our behavior. Physician's will is the most important determinant in treating infection and avoiding antibiotic abuse, preventing drug resistant bugs, in my opinion. Antibiotic stewardship program has to be strictly followed for reducing the number of infections in your unit, and the dosage of the antibiotics as well. Ideally, as far as possible, they should be monitored. You can check the drug levels as far as possible. Broad spectrum antibiotics to start with, but de-escalate the antibiotics and modify the antibiotics as per the culture results and use them for the duration specified rather than using them forever. Differentiate between commensals and pathogens. It is extremely difficult to get rid of the bacteria, as I have shown in the first couple of slides. They have been living around us for 3.5 billion years. Narrow spectrum antibiotics for the right period of time is the way to go. An appropriate dose of antibiotics as per pharmacokinetic and pharmacodynamic data and as per the drug levels, they are warranted. In some cases, colleagues have tried cytosorb therapy as well. It might be helpful to some extent, but the cost factor um, is the prohibitive one in this. Circuit and oxygenator change as well. For infection sake, we don't recommend change of circuit or oxygenator because it's the same blood which is circulating in the body, and it will come back again, and it can go on to your next oxygenator as well after it has changed. Usable antibiotics are, it is a very difficult question to answer because it depends on your antibiotic uh, policies on the unit and what sort of bacteria you tend to isolate on your unit, and accordingly you can select broad spectrum antibiotics to cover as the initial antibiotic of choice. Send the cultures prior to starting antibiotics on them, and I don't think any of you will be getting your patients without starting on antibiotics at a referral center. So most likely you will be working in a period where you don't know what you're dealing with, or you might be aware of what you're dealing with either. So this has to be as per the institutional practice. Antimicrobial surfaces, this worth thinking about this. Microorganisms are known to survive on non-antimicrobial animate touch surfaces such as bed rails, bed trays, call buttons, bathroom hardware, etc. for extended periods of time. So there is some information available from the US Army studies showing that antibiotic grade copper or the copper is very helpful in killing bacteria, fungi, and viruses to the extent of 99.9% when it is used. What it means is if the bed rails or the trays you use in the patient vicinity, if they are made of copper, the bacteria which fall on these surfaces will be killed to an extent of 99.9% in an hour's time. It is a costly way of designing your ICU, but definitely cost effective way of designing the ICU. In few years time, it will certainly pay off, and it has been tested. You can check this antimicrobial copper on the internet as well. It has been tested and found to be very useful and efficacious in reducing your need of the antibiotics in your ICU. Use the interventions as a bundle, and in my experience, I have always found it to be very useful when it is used as a no blame culture. So, looking at the ways we practice educating ourselves training under seniors observations and train the staff with scientific views. That is very important. Review our situation openly. Your situation would be different from somebody else's situation. Understand the lacunae, tighten the loopholes, and with further advances, you can make it forward. In my opinion, the stewardess who tend to maintain hygiene on the floor by repeated cleaning on ICU, they contribute a lot to our infection control policies, and I really appreciate them. Without them, there is a very high possibility of transmitting infections on the unit and from person to person as well. So I have gained lot of experience with observing the patient, observing the way our colleagues, nurses and doctors uh, behave on the ICU. Just if you stand in one corner and observe how people might be breaking the barriers, it is unintentional, but it does happen. But with no blame culture, if you focus attention to that part, that makes your ICU better. So the take home message is the basic principles are very important: hand hygiene, making sure the environment is free of infection, changing the way we do things, antibiotic de escalation after completion of the antibiotic course, no blame culture, and examining the cost effectiveness of interventions. Using interventions as bundles has a long way to go in preventing and treating infections on your unit. My last question is, if you believe operation theater in your hospital is the best way to do surgeries or maintain germ free atmosphere, why don't you maintain the same principles on your ECMO ICU as well? Thank you very much for patient listening. If there are any questions, I'm happy to answer.